Sarah, are we ready to jump in?
Let's do it.
Let's do it. All right. So my name is Dr. Yael Joffe, or Yael, and I am the founder and chief science officer of epigenetics. But most important, I would like to introduce my friend and my colleague, Dr. Sara Gottfried. And Sara is a physician. She's a researcher, an author, an educator, and a mother. She graduated from Harvard Medical School and MIT and completed her residency at UCSF. She's a global keynote speaker and the author of 4 New York Times bestselling books about hormones, nutrition, and health, and we'll be dabbling in there a little bit today. Her latest book being The Autoimmune Cure. She is a clinical assistant professor in the Department of Integrative Medicine and Nutritional Sciences at Thomas Jefferson University and the director of precision medicine at the Marcus Institute of Integrative Health. Her focus is at the interface of mental and physical health, N of 1 trial design, personalized molecular profiling, and we'll talk a little bit about what that means, the use of wearables, and how to leverage those tools to improve health outcomes. So welcome, Sara.
Thank you so much. So happy to be here with you and with all of our people.
Excellent. So we are now ready to jump in, and I see the chat is enabled so everyone can tell us where they're from and how we're doing. But as you saw when we advertised this wonderful presentation, we're going to be really focusing on 3 things. The first is hormones. The second is the brain and brain health. And lastly, but definitely not least, we're going to be talking about autoimmune and the amazing book that you put out. I think it was in March 24, that was recent. Okay, so we're going to jump in with hormones. So you've published actually 3 books on hormones: The Hormone Cure, Woman, Food and Hormones, and the Hormone Reset Diet. So I figure this is definitely a great place for us to start. So traditionally, we have been taught that there is nothing we can do about our hormones as we age. So let's talk about whether you think that's true.
I totally disagree. There's so much that you can do to modulate your hormones. That includes lifestyle practices, the way that you eat, move, think, and supplement. It includes the way that you work with your genetics, which we're definitely going to dive deep into today. And it also includes the use of bioidentical hormones when they're indicated. So when I was growing up, when I was first starting medical practice, it was at a time 30 years ago when hormone therapy was really common. In fact, I was taught to convince women to go on hormone therapy. And what's happened over time as a result of the Women's Health Initiative, which we can also talk about, is that the pendulum swung away from hormone therapy. And now finally it's swinging back toward hormone therapy. So I'm a big fan of managing your hormones as you get older. And we're not just talking about estrogen and progesterone in women here. We're talking about testosterone in men. We're talking about DHEA, which is a really important immunomodulator. We're talking about cortisol, and we're especially talking about insulin.
Well, you kind of jumped into some of my next questions, because actually, just in my experience, was exactly the same as yours, which is I kind of lived through the time where, especially my mother's generation, where everyone was putting on HRT, and then there was this kind of breast cancer fear around, well, if I go into HRT, and I know this, and when I use the word HRT, I'm talking about hormone replacement therapy, and use the terminology of bioidentical hormones. So maybe you can just help us unpack this a bit. One is, what was the fear around breast cancer and hormones? And should we continue to have concerns around that? And of course, we can talk about genetics because that helps in that conversation. And the second one, if you can just help us understand better, what is the difference when we use the term hormone replacement therapy, HRT, which is part of our mainstream medicine, and then the words bioidentical hormones, which is what we tend to use?
Hormone replacement therapy, I'll start with your second question first because it's easier. What we know is that hormone replacement therapy, HRT, has referred to all different types of hormones. So it's referred to synthetic hormones, hormones that are made in a lab, hormones that are structurally very different from the type of hormones that we produce inside our bodies. And it also includes bioidentical hormones. So when I'm specifically calling in bioidentical hormones, what I'm referring to is the hormones that are exactly the same as the hormones that your body has made. So, the kind of, as an example, the bioidentical hormones that I prescribe tend to be estradiol, which is the most potent type of estrogen that the female body makes. We make it mostly during our reproductive years. And then when you go through the transition from reproductive years to perimenopause, when your ovaries start to sputter and don't make as much of these hormones, and then into menopause, which is when you have your final menstrual period, what we're talking about is a decline in estrogen over that period, in this case, estradiol. There's also a decline in the production of progesterone, which is produced when you ovulate. So, progesterone is also really important. You can think of it almost like nature's Xanax. It's really important for soothing, it's really important for um, reducing anxiety in the female body. So that's the difference between bioidentical hormones, structurally identical to what your body made or continues to make, versus hormone replacement therapy, which includes synthetic hormones. Now, your second question is about breast cancer. And, what I found is that living in the female body, most of us have a fear of a couple of things. I would say breast cancer is probably number one, at least among the patients that I take care of. And number two is Alzheimer's disease. So, when it comes to breast cancer, what we know is that synthetic hormone therapy, the kind that was studied in the Women's Health Initiative, which was published in 2002 and has mostly been disproven in the past 20 years, what we know is that that study was designed to look at cardiovascular disease. So, the people who designed it, the Women's Health Initiative, designed it to look at whether you develop heart attacks or die of a heart attack or have um, the precursors to a heart attack as a result of taking hormone replacement therapy. The hormones that were used in the Women's Health Initiative were synthetic, Premarin and Provera.
Yeah.
What they found after 5 years of running this trial, the Women's Health Initiative, was that there was an increased risk of breast cancer. We think that is primarily a result of the Provera, the synthetic progestin that was given. Now, 20 plus years later, going back and looking at those data, and I'll just say that I hope we can finally put the nails in the coffin of the Women's Health Initiative because it has gotten so many millions of women to stop their hormone therapy and to suffer in silence. And that's something that I just I can't abide. We can't continue to do that. So, with the risk of breast cancer, I don't want to get too much into the nuance, but they stopped the study because of the risk of breast cancer. The the blame really sits with Provera, which I haven't prescribed for 30 years. It's not something that I think is good for the female body. I only prescribe natural progesterone, bioidentical progesterone. But the other thing that they found is that the synthetic estrogen that they gave was associated with a lower risk of breast cancer and a lower risk of breast cancer mortality. So you can see how this starts to get confusing for people. But here's the bottom line: we think that synthetic hormones, such as Premarin, well, in this case with breast cancer, Provera, we think that increases the risk of breast cancer. We don't want to prescribe that. We only want to prescribe bioidentical hormones, which we think are safer. And mostly from the research coming out of Europe, including studies the size of 500,000 people, we see that with natural progesterone use, there's a lower risk of breast cancer.
Sure, so much in what you said. So it's interesting. So let's start off with, you said when you live in a woman's body, you have two concerns: breast cancer and Alzheimer's. And you actually just defined my family history. So my father has Alzheimer's and my mother had breast cancer. So it just like resonated so much with me. But I also want to just reference two people I know just to illustrate why this area of hormones is so important for us to talk about, why your books are so important. So I have, one is a family member, one is a friend. So my friend is younger than I am and she's in her 40s. She can't sleep. She's anxious. She's got brain fog. She's miserable. She's rude to her husband. She's rude to her kids. She eats well. She exercises, but
Is she rude? So is she rude or is she just speaking the truth? That's what I want to
I
know.
can't say that.
See, I would ask her that. I would ask her
Yeah, but by her statement, she said she was awful to her family in a way that she has never been. So I don't know if it was truth or not, but she definitely wasn't handling her relationships very well. So she goes to a doctor in the primary care traditional medicine and says, there's something wrong with me. I can't sleep. My brain's not functioning. And they say, no, you're fine. And she goes, it could be my hormones. And they said, no, you're in your 40s. There's no ways it's menopause. So it's not something else. So this goes on. I'm not even going to tell you for 18 months. She goes from doctor to doctor saying there's something wrong with me. And they're like, no. So eventually they send her to, you can see where this is going, a psychiatrist. And the psychiatrist does an evaluation and says, you've got ADHD. That's what's wrong with you. And they put her on Ritalin. Well, you can imagine how well that went. So that was a disaster. So she takes herself off Ritalin. So she goes to another doctor, and the other doctor says, no, you're too young for menopause, but I'm going to put you on an antidepressant because that's the problem. And I know this, I've heard this a million times, right? They put her on antidepressant. She goes, no, I'm not depressed. I've never been depressed. There's something wrong. I can't sleep. I'm anxious. My brain isn't functioning. There's something wrong. 18 months, she goes from doctor to doctor. She said she went to 10 doctors, including gynae obstetricians, including psychiatrists, including primary care. So that's one case study that I want you to just address, if you don't mind. And the second case study is a family member who is around my age, around our age, and can't sleep. Is the main thing. Can't sleep. Otherwise kind of functioning and everything. Goes to the doctor. Doctor's not interested in discussing hormones. So eventually lands up going to an alternative functional doctor who's not part of the primary care system, isn't paid for anything. And she goes, oh yeah, let's put you on some progesterone and an estradiol patch. And first time they've slept in years.
Yep.
So maybe you can just address those two case studies, because I wish they were exceptions and unusual, but I know that they're not.
They're not. And they are the reason we need a revolution. So, for the woman in her 40s, what we know is that perimenopause starts for most women between 35 and 45. And it can be subtle. It can be a shift in your periods, like they might go from every 28 days down to every 26 days. But that's a sign that your progesterone is not being produced at the same level that it once was in your ovaries. Now, I just described progesterone as nature's Xanax. It is so critical for helping you sleep at night. It's so critical for self soothing. It is anxiolytic. It helps to reduce anxiety. And so, one of the most common symptoms that I see in that age group from 35 to 45, and it could happen later, like up until your 50s, is that women notice the decline in progesterone. They can't sleep like they once did. They wake up at 2 a.m. ruminating, can't fall back asleep. They notice that they feel more anxious than they used to. So these are all signs that your ovaries are not making as much progesterone as they once did. And you can measure that. You can run a blood test and look. And why doctors don't do that? I mean, we can talk about the reasons, but um, the problem is there's a culture of dismissing women when they're speaking their truth. There's a culture of telling women they're just getting older and they have to get used to the fact that they're just not going to sleep. Sleep is so foundational to a woman serving her mission, whatever that is on the planet. We need sleep. And often the problem, what's missing, is we don't have enough progesterone. So I wish that first friend of yours saw me or saw someone like me who could tell within about 30 seconds that she was in perimenopause. And typically, what we do at that point is we start with some progesterone. So we give natural progesterone at night, helps you sleep, as you described in the second um, family member, and it helps to reduce anxiety. Women feel often transformed inside of a day with being treated with progesterone. Now, it's not a panacea. There are some people who have mood effects with progesterone. I would say with natural progesterone, it's tiny. Very few people have a problem. Whereas with the synthetic progestins like Provera, people had a lot of mood issues. So I wish that first woman, instead of this long march of 18 months ending up on Ritalin for ADD, I wish she had seen someone who could collaborate with her and say, I got you. I understand. You're in perimenopause. Here's what's happening in your body. Here are your options. You know, when you're early on in your 40s, sometimes you could take an herbal therapy like Chase Tree, Vitex. That helps to raise your progesterone levels. You could take vitamin C at doses of 750 to 1,000 milligrams. That raises your progesterone. So there's lots of things that you can do short of taking bioidentical hormones. There's lots of lifestyle changes you can make that I would recommend for that first woman. Now, the other point I want to make too is the way that we diagnose ADD is fraught. There's problems with it. And there are a lot of girls, young women, and women in their 40s. I'd still consider them young because they're younger than us, um, who don't get diagnosed properly, who have maybe a trauma history. And that's part of the driver for attention deficit. But what I would assume first is that it's a woman's hormones. I would assume it's her hormones until proven differently. So that's where I start. What are your hormones? What are your symptoms? How do we put this together? Which of these solutions would you like?
Great. And I mean, the good news is she did eventually find someone who heard her. And I love what you said about we're not necessarily heard. I think that's absolute truth. And not all of us are health professionals who can advocate for ourselves. She did eventually find someone, and she was transformed in literally 24 hours. And same for my family member who literally went from not being able to sleep for years to being able to sleep. So it's something so simple. I think we could talk about this a long time, but we have so much to talk about. And of course, you mentioned the word trauma. This is your amazing recent work. I'm going to save it for the end because it's beautiful work and I want to give it time. I want to just take this time because we could spend an hour on hormones, and I want to make sure we get to talk about, and we can talk about ADHD in the brain when we get there, is that let's talk about genetics, and so just before we dive into the detail, whenever we think about the word genetics, we're always thinking about who am I and why do I respond to the world differently? And that could be diet, lifestyle, stress, trauma, hormones, exercise, pretty much everything we encounter every minute of the day, we respond differently. And so we always have that in mind when we discuss genetics. So in this case, we're going to talk about the genetics of hormone metabolism, or how our body manages hormones. And so we ask ourselves the question, how are we different? And how does knowing our genetics help us understand this hormone conversation? So I'm happy to dive in and give a little bit of background into it, Sarah, and then perhaps you can step in and talk about, because you've been working with 3x4 Genetics for a very long time. I know you do all your patients with a genetic test, and maybe you could just give more of the kind of practical experience. So, good. Okay. So, as Sara mentioned, there isn't one hormone that determines, our hormone status. And you mentioned many from cortisol and estrogen and progesterone and also testosterone and DHA. So what often happens is you'll go to a doctor and you'll do a hormone test. There's some kind of basic blood work, but there's also some more advanced testing, what we call the Dutch test. And you get the results of the blood test, but you don't understand the why. And the why is, why are my hormones like that? Why is my DHA and my testosterone not converting? Why is my estrogen going down this pathway and that? So estrogen, and Sara can speak to this, when it is metabolized in the body, goes down a couple of different pathways. And some pathways are optimal and they generate great health and it's the outcome we want. But there is a pathway in the body that the estrogen will travel down that is associated with more susceptibility to risk around breast cancer and others. So we ask the question of the why. And what's so helpful about using genetics is it gives us the insight to understand where in our pathways of our hormones is it not functioning optimally. And if we can understand that, we can then intervene at the exact point at which we need to optimize it. So this is where we bring in a general conversation that we've been having about hormones to being hyper-personalized. And we know we spoke about Sara's work in N of one, in personalization, the ability to know what my hormones are doing and where we need to step in and truly optimize. So that is, I know, quite a high-level understanding of the role of genetics, but in 3x4, we have what we call a hormone pathway where we dive in and we look at all the genes that will impact your hormone metabolism. So I'm going to throw it back at you, Sara, and maybe you could talk a little bit about your experience of working with genetics here.
Working with genetics is essential. The way I was taught to work with hormones, and originally I was board certified. Well, I'm still board certified as an obstetrician gynecologist, but I went broader. And, I'm someone who really thinks that this interface between genetics and biomarkers is the way that we personalize care. And I think that's the way you get the best outcomes. I was taught a concept similar to that in medical school. So at Harvard Medical School, one of the things they teach us is what's called quality of evidence. And the lowest quality evidence, even at Harvard, is expert opinion. Next up from expert opinion is retrospective case control studies. So you take a group of people, you look kind of back over time, what's going on, say, with their hormones. Next up is observational studies. So not randomized trials, but things like the nurse cell study. Next up is randomized trials. But the problem with randomized trials, especially as they relate to hormones, especially as it relates to the Women's Health Initiative, is that you're getting medicine for the average. You're getting answers for the average. You're not getting answers for the individual. The way you get answers for the individual is to do N of one experiments. And I think you need genetics together with biomarker testing to design the best N of one experiments. So what does that mean? By biomarkers, I'm talking about blood tests. I'm talking about urine tests where we're looking at, for instance, the different types of estrogen that your body can make. And as you described, Yael, there's the more protective types of estrogens that some of us make. And then there's the more, I think of them more like fraternity party type of estrogens, which can cause problems and they can increase the risk of breast, endometrial, and prostate cancer. And we want to be tracking these things so that we can reduce the risk of some of these outcomes that we don't want. So I think it's essential that we're right at that border of knowing what someone's genetics are and then putting it together with blood testing, sometimes stool testing, sometimes urine testing, and often adding a layer of wearables can also be helpful. So that's what I find in my practice. I run genetics testing on every single client that I take care of. I've looked, I started doing genetic testing 30 years ago because in OBGYN, we got a lot of genetics training because we were looking for people who are at risk for um, particular genetic outcomes, whether that's trisomy 21 or cystic fibrosis. So over the decades, as I've tracked different genetics tests, I really feel like 3x4 stands above the rest. And that's uh, a huge credit to Yael, your work with designing a genetics test that's pathway based. So instead of going on a fishing expedition for lots of different genes and gene variants, you design this test to really look at pathways. So one of those pathways is your hormones, whether you're male or female. Another set of cellular pathways that you can look at with 3x4, which maps to your hormones as well. That includes your inflammation pathways, your methylation pathways, which is how we inactivate some of those estrogens that we don't want to be making, your detoxification, which is so critical. And I can tell you, most of my clients, the kind of people who come to see me because they're failed by the medical system, they often have detox problems. They've got sluggish detoxification. I have sluggish detoxification, so I know a lot about it. And then oxidative stress, which is kind of like rust in the body. It's one of those concepts that most people are like, what's that again? But those are the cellular pathways that also can influence your hormones.
And then I'll just throw one more in there, which is called glucose and insulin. That we
Yes.
always want to look at the glucose insulin. So what Sarah's referring to is most genetic testing companies, and I've been in like 30 years now in genetics, is they look at individual genes and try and make these assumptions around what does it mean, that individual gene. And they can be informative, they can be insightful, but they're not powerful enough for someone like Sarah to be able to make clinical decisions. So what we've done at 3x4 is we've looked at all the genes in a pathway. So a pathway could be a biochemical pathway like glucose and insulin. It could be a hormones, it could be inflammation, and we group them together. And that obviously helps us understand in a more powerful way how genes are influencing it. So thank you for that answer. We're going to move on because I really want to make sure we get time to cover brain and autoimmune, which will kind of tie it all together. So in the brain space, Sarah, you have also published a book. It was called Brain, Body, and Diet, Brain, Body, Diet. So let's talk about brain health for the moment. And when I think about brain health, I actually think of it in two different ways. So this is kind of a 3x4 way, I guess. The one is cognitive decline. So that's when it's memory loss. It's that Alzheimer's conversation coming back again. But of course, it doesn't only have to be Alzheimer's. It can just be loss of memory, dementia, or any aspect of that. So that's one way I think of brain health. And the other side is around things like, and we touched on this already, anxiety, depression, ADD, ADHD, addiction behavior. And so for me, all these things need to be thought about when we think about how do we optimize and think about what brain health means to us. And is this, again, an inevitability, which I think is how it's always been seen. Of course, you're going to lose your memory. Of course, you're going to, get brain fog. Of course, as opposed to something, again, that is in our control.
I would say it's entirely in your control. Entirely in your control. So it's you mentioned that you've got a paternal history of Alzheimer's disease. I've got a really strong maternal history of Alzheimer's disease. So the women are affected on my mother's side. I grew up with a grandmother who I remember her driving me around in her old Oldsmobile in the 70s and getting lost on, the 3-mile trip back from the school bus stop. So I've got a really close personal relationship with cognitive decline. And while there are some um, situations where early Alzheimer's can be diagnosed and it's a genetic cause, mostly what we're talking about here is the ApoE4 genotype, the risk that's associated with that. And I want to back up a little bit because what we know is that as women transition from their reproductive years, so say their 20s and 30s, to perimenopause in their 40s, usually sometimes 50s, to menopause, there's a significant change that happens in the female brain. So we call this cerebral hypometabolism. The easier way to remember that is it's like a slowdown of brain function. So the energy slows down. You may notice that you just aren't quite as quick as you used to be. Maybe you lose the word that was on the tip of your tongue. You walk into a room, you're not sure why. There are these changes that happen in the female brain. And what we know is that they happen in 80% of women over the age of 40. So this is the work of Lisa Mosconi, who's a good friend of mine, who's at Cornell. And she's found that the primary regulation of your brain's use of energy is by estrogen. So as estrogen starts to decline in your 40s and into your 50s, a lot of women notice that they just can't think as sharp as they used to. So they've got more brain fog. They may notice word finding difficulty, as I mentioned. They may notice other symptoms like the insomnia, hot flashes, night sweats, mood changes. All of these things are associated with reduced cerebral metabolism. So the way that the mitochondria are functioning in the cells in the brain is starting to falter. And estrogen is what regulates this. So when it comes to cognitive decline, I feel like it's, in my mind, the most compelling reason
Yeah.
to determine if you're a candidate for hormone therapy, in this case, bioidentical hormone therapy. But there's so many other factors too when it comes to cognitive decline. And the way that our friend Dale Bredesen talks about it, I think is very helpful. He works mostly with people with Alzheimer's disease. I don't work with people with Alzheimer's disease. I work with people who are in their 30s, 40s, and 50s who are trying to prevent Alzheimer's disease. And that's when you want to prevent it. It is a disease of middle age. Middle age is 40 to 65. And so while estrogen, progesterone, and testosterone are critically important to keeping your brain young and healthy, and you've got choice about whether to take those, depending on whether you've got contraindications or not. There's so many other factors that are important. And Dale talks about when you develop Alzheimer's disease, it's like you have 36 holes in your roof. And so when the rains come, if you've patched most of the holes, you're still going to have a flood. You're still going to have water that's coming through the building unless you patch every single hole. But if you wait until 65 plus to patch all those holes, it's a lot harder to do it. Whereas the patients that I take care of who are in their 30s, 40s, and 50s, maybe they've got 3 holes in the roof or 7 holes in the roof. Maybe they've got a problem with their glucose and insulin, as you mentioned. They've got a genetic risk of developing prediabetes or diabetes. And that's something we can modulate with a continuous glucose monitor, maybe, or personalizing the way that they're eating or changing the way they exercise. There's the risk of inflammation and managing that as you get older. Now, being able to track things like high sensitivity C-reactive protein, the neutrophil to lymphocyte ratio. These are some of the things that I track on the dashboard of my clients, whether those are professional athletes, Olympic athletes, executives, or women in their 40s who are noticing this brain shutdown and they don't want this to get worse. They want it to get better. So that's how I think in terms of cognitive decline. I think genetic testing is really critical, not just for ApoE4, but for looking at all these other factors that map to your cognitive function. And then you also mentioned this issue of attention deficit, of difficulty with focus, of um,
Anxiety.
people anxiety. And I agree. I do sort of think of them as two separate things. And this once again is a place where there's so much you can do to manage it. I'm someone who I've been diagnosed with ADD. I was diagnosed in my 40s because it's really common in perimenopause that you've got increased symptoms of ADD. And I was treated with different, basically amphetamines
Mhm.
to treat it. And what I found was that it wasn't a good fit for me. A better fit for me to deal with my particular genetics related to COMT and uh, dopamine receptors that don't work very well. All these things that we can measure with the 3x4 test. What I find is really helpful is meditation, I need more sleep than most people. Women often need more sleep than men. So I do best with like 8.5 to 9 hours. And then there's certain supplements that are really helpful for me that help to kind of work around my genetics so that I've got more dopamine available and I'm able to focus better. So those are some of my initial thoughts. And I know you want to jump in here. So
I
you
do.
please do that.
I do. So, it's such an interesting, and I'm going to talk about the anxiety, depression, behavioral side of the brain because it's one of the areas where genetics is just so interesting. So there is this assumption that every person who suffers from anxiety and depression has low dopamine, low serotonin, and that we need to raise the levels of dopamine and serotonin. They're the feel good hormones to have optimal function and also treat anxiety and depression. And we have a case study of a patient that came through 3x4 that really shows so clearly why genetics is so fundamental to understanding who we are as patients. So when we look at the genes, remember we do pathways, so we look at all the genes that impact anxiety, depression, and all these what we call neurotransmitters, which are brain messages, really, that determine how our brain functions. And dopamine, serotonin be the ones you commonly hear, adrenaline, noradrenaline are some of the others. And what we find is that, remember, your genes determine why we're different. And in some of us, the changes in our genes, which is the differences in our code, which is what we're testing in 3x4, determine that actually we're not very good at breaking down dopamine and serotonin, as opposed to some others who would be breaking down dopamine and serotonin too much and their levels are too low. So an individual who goes to a clinician and says, I'm suffering from anxiety and depression and I've got insomnia and restlessness, and they're like, oh, you must have low dopamine serotonin, and I want to put you onto an SSRI, which is going to boost those. And for someone who can't break down those dopamine serotonin, you're adding to the problem anything. So sometimes the same symptoms are actually telling the underlying cause is actually very different. And this is where we talk about genetics as a screening tool. Genetics you only do once in your life. 3x4 you do once, you never redo it. It's so important to have this information as a baseline before you say, well, I have this and I'm going to do that. And so that's just one thing, Sarah, I wanted to make clear that there is no one solution. And you've spoken about this hyper-personalization, but if we can understand who we are right up front, we can avoid the trial and error of, like my friend that I described, we're going to try Ritalin, which is a stimulant. We're going to try anti-anxiety medication, but actually what it was hormones. So this just kind of comes back to our conversation. I don't think you want to add anything to that.
Well, it's a critical point. One of the reasons why I write books about hormones is that they're not tested, they're not considered, they're not, it should be a foundational part of understanding a person. So I'm a big fan of doing genetics testing and then also running a hormone panel. I think everyone deserves that. And what I was taught when I went through my training was that if you're a woman of a certain age, 35, 40, 45, 50, and you want a hormone panel, I was taught to talk the woman out of it because
Yeah.
hormones change too much. And then in the same program, I was taught that if a woman is trying to get pregnant and she's having a hard time getting pregnant, test every hormone, test her thyroid, check her cortisol, look at her testosterone, what's happening with DHEA, look at progesterone. Is she ovulating? What's her estrogen level? What are the control hormones of estrogen and progesterone, like FSH and LH? So we check every single hormone and suddenly they don't fluctuate too much if you're trying to get pregnant. That doesn't make sense. So
Right.
it's a double standard. And I would say we all deserve to look at the why, to look at the root cause with genetic testing, and to put that together with hormone testing.
Excellent. Thank you. Yes, I agree. And I'm going to close out the brain part just with one comment. And I'm kind of going back to Alzheimer's and cognitive decline, but we do a lot of work with Dr. Dale Bredesen. We're going to be doing a wonderful webinar with him in a couple of months, and his work is really groundbreaking. But the thing that really resonated with me as someone who has such a strong family history is he always states that Alzheimer's is preventable disease. Like cardiovascular diseases and like diabetes is, we need to start thinking of Alzheimer's as preventable, as all the things, the 36 holes that we can do to not get Alzheimer's. And when we can feel ourselves having some decline, there is a huge amount that we can do. And so, I want to leave it on that because there is this deterministic idea around Alzheimer's that is absolutely not true. So hopefully we will see again a movement, a revolution around what we can do in terms of brain health. Okay, I've been saving this for last, but I'm really excited because again, it's so funny because like every single thing we talk about is personal for me. And here we go again. We're going to talk about autoimmune. Sara, your last book that you published was The Autoimmune Cure. And unlike your previous books, this really was a huge jump or development in your understanding of disease. Now, I developed thyroid Hashimoto's a couple of years ago, and it was an absolute shock and surprise for me. And I just couldn't fathom with the lifestyle I led and the things that I did and what I knew and my genetics, how is this possible? So I'm going to lead with that because it's so relevant to the conversation we're going to have. So before we jump into what you've written about in this book and why it so challenges our paradigms about how we've understood autoimmune, perhaps let's ask the question and you can help us answer. Why am I hearing from every single person that about autoimmune, whether it's thyroid Hashimoto's or whether it's rheumatoid arthritis or whether it's Crohn's? Like, why is autoimmune suddenly so prolific?
The rates of autoimmunity are increasing dramatically. And we're still trying to understand all the reasons why rates are increasing. But I can tell you that what I've tracked over time is that more than 30% of my patients have autoimmunity. Most of them don't know it. And we both work with Mark Hyman. He has a test now. He's had more than 100,000 people perform this test. And similarly, in 100,000 healthy people, people like you and me and everyone on this webinar, 30% of them have positive anti-nuclear antibodies. So what is autoimmunity? It's the precursor to autoimmune disease. There's more than 100 known autoimmune diseases. And even though they're very different, rheumatoid arthritis affects your joints, multiple sclerosis affects your neurons, the myelin sheath, Hashimoto's thyroiditis, which you described, Yael, affects your thyroid. Even though these autoimmune diseases affect different organ systems. They have a similar root cause. And what we know is that people tend to have positive blood tests that can occur for 7 to 14 years before they develop or get diagnosed with the disease. So I'm really interested in why we're seeing these rates of autoimmunity increase. The groups that seem to have the fastest increase are adolescents and men. Now,
Oh,
women were already, we already got the short end of the stick when it comes to autoimmune disease because 4 out of 5 people with autoimmune disease are women. But we're seeing an increase in uptick in men and adolescents, which really concerns me. So why is that? That's what you asked. So I saw this 30% affected by autoimmunity before the pandemic. We think the pandemic has worsened the rates of autoimmunity. We think some of that is related to the immune system getting overactivated. We know women are especially vulnerable to immune system dysregulation. We also think that the experience of trauma has become more common, especially, we never had a period in our history of sheltering in place and the isolation and the loneliness that went along with that. And even if it's not a capital T trauma, like surviving 9/11 or the Holocaust, these small T traumas, like the experience of sheltering in place, the isolation, we know that isolation and loneliness increases autoimmunity. That is well demonstrated.
yeah.
So we're seeing this increase. I think there's so many different factors. There's more leaky gut than ever before. Some of that is related to environmental chemicals like glyphosate. We also think that our food supply has dramatically changed. We're being exposed to ultra processed foods that can stimulate the immune system in ways that didn't exist 100 years ago. So those are some of the speculations for why the rates have increased. But you're absolutely right that we are seeing exponential rise in autoimmunity and autoimmune disease, and we need to understand why.
So, and I think the one valid point is, and it comes back again to hormones, is so much depends on the doctor that you land up having the conversation with. Because if I think of my history, like if I hadn't, because of my health status and the decisions I made, if I hadn't gone to a doctor who was a functional integrative doctor, we would never have tested for a thyroid panel. We would never have tested in a million years for antibodies. I would not have known that I had antibodies, and I would not have made the changes in my life to be able to address that. And sometime in the future, who knows when, we may have discovered that I had Hashimoto's, by which time a lot of the damage would be done. So I do think it comes back again to the same conversation. If we're able and lucky enough to be able to access functional, doctors who are functionally trained or integrative trained or any of these kind of more advanced training, we are going to be able to find out this information. So I think that's extremely valid around the autoimmune conversation for sure. But let's talk about, before we talk about, actually, I don't know what to talk about first. I want to talk about genetics and epigenetics, and then I want you to talk about trauma. So I'm going to kind of set it up. Because you said that when we went through the COVID epidemic, isolation, loneliness, disconnection had such a fundamental impact on autoimmune. And so I want to just go back and talk about genetics and epigenetics. So what I've been speaking about up until now is the concept of genetics, which is we have a genetic code. We're all different in our genetic code, and it's the differences in our code that determine how we respond to all these different things we've spoken about. And that's what we test for in 3x4. But that's 50% of the conversation. The other 50% of the conversation is this beautiful conversation around epigenetics that everyone thinks they know what epigenetics means, but it's really hard to kind of conceive of. So I'm going to give us a very simple definition of what I mean by epigenetics in the context of this conversation. So while we can understand our code, which never changes, and how that makes us different, every single minute of every single day, the choices that we make in our life, the food we eat, the toxins we exposed to, the isolation we may have endured, the seasons. I live in Seattle. The seasons, I always think about the seasons, exposure to radiation, anything like that will fundamentally change our gene expression. And what I mean by gene expression is that our genes are continuously being switched on and switched off. When a gene is switched on, it makes the protein. A protein is an enzyme or a hormone or a neurotransmitter, a brain messenger. When a gene is switched off, it stops that hormone or that enzyme from being made. So epigenetics is epi being above genetics. It's not about the code. It's about every single decision we make or an environmental influence that is we're impacted by will change our gene expression. And that has a fundamental change on our health. And I'm just setting you up here, Sarah, and then I'm going to hand it back to you. So when we think about health outcomes, we always want to think about genetics, understand your patient, use it as a screening tool. Who are we? And then epigenetics, what has happened in our life currently? What has happened in our life in the past that is changing the gene expression, which is changing the way our body results. And one of my great aha moments was I always thought that epigenetics was only about nutrition and diet, to discover that every single thing. And when we think about COVID, when we think about isolation, disconnection, and loneliness, those things change the way genes switch on. When we are joyful and connected and laughing and we get a hug from someone, we're changing gene expression. So I'm gonna hand it back to you, Sarah.
Well, thank you so much for the primer on genetics, the set DNA code that we have versus epigenetics, which is above the DNA. It's the way that the DNA talks to our body. And you are absolutely right that the experience of trauma can change DNA expression through epigenetics. And this has been measured for the past few decades, especially the work of Rachel Yehuda, looking at survivors of 9/11, women who were pregnant, who were in the terrorist bombings, and what happened with the way that they managed cortisol and what happened in their offspring. Same thing with the Holocaust and what happened with cortisol clearance, not just in the survivors, but in the offspring of the survivors. So the way that I think of this, you don't have to understand the science intimately. The way I think of this is that these are like soul wounds.
Mhm.
And I wrote a book about this younger, about genetics and epigenetics and how with some conditions, epigenetics has a huge influence. So as you described, yes, lifestyle factors are so important. The way that you eat, move, think, supplement, feel. But then we also really want to be thinking about the role of triggers like trauma. And if we take a step back, one of the things that I cover in the book that I think is fundamental to understand when it comes to autoimmune conditions or really any chronic condition is that to develop an autoimmune disease, there's three factors that you want to keep in mind. There's genetic predisposition, there's increased intestinal permeability, leaky gut, and then third is a trigger. And that trigger could be an infection, could be a parasite, it could be the virus that causes COVID, it could be trauma. So those are the three factors that we really want to be thinking about. Alessio Fasano at Massachusetts General Hospital in Boston is the one who first came up with this concept that you have to have all three legs of the stool to develop autoimmune disease. So when, I'm someone who tests everybody for antibodies against their thyroid. I test every single patient for their genetics. I run a 3x4. I test every single patient for anti-nuclear antibody. And what I find is that it's not just autoimmune disease that has the three legs of the stool, it's autoimmunity that does. Now, the good news, what's really empowering about the three-legged stool, can't do anything about your genetics, but you can do something about leaky gut. and you can do something about triggers. So that's where the empowerment comes in. That's where you can modulate your risk going forward by working with those in a way that supports your health.
Do you want to talk a little bit about what that looks like? I mean, it's such a fundamental part of the book about, so genetics we get, leaky gut is, we want to do gut health, we want to address and there's all kinds of things. But let's talk about the third part, which is if there are triggers and there has been trauma in the past, I think there's always, again, been a bit of like a fatalistic, well, that's me. That is, and it's in the past and it doesn't matter. And there's nothing I can do about it. And I know that this is where some of the most exciting research and clinical practice is happening. So can we focus on that for a little bit?
Of course. Yeah. So when it comes to leaky gut, in the book, The Autoimmune Cure, I talk about the things that are most proven. So elimination diet is really effective at improving leaky gut. The thing that causes leaky gut probably the worst and the most commonly is alcohol. So cutting out alcohol is a really important part. It also helps your brain, helps your hormones, because if you are drinking more than 2 servings of alcohol per week and you're female, you're increasing your risk of breast cancer. You're also shrinking your brain and making more of these frat party type of estrogens that we don't want to be making. And then there's supplements like L-glutamine, aloe, natural things that you can do to soothe the gut lining and to help the tight junctions improve. So with triggers, what I got really interested in my medical practice is the role of trauma in particular, because as we were seeing more trauma in our daily experience, I felt like it was measurable. I could measure dysregulation in my clients, whether that's with an aura ring and looking at heart rate variability, daytime stress, what's happening with sleep at night. There's a way to measure the amount of dysregulation that a person has. And trauma often can lead to that. So in my book, you can determine your adverse childhood experiences score. I think that's a really important place to begin. My A score is 6. I have a high A score. This is not a test you want to score high on, but it's a measure of the amount of adverse experiences you had as a kid until age 18. And some of them, are pretty hard to avoid, things like divorce. Some of us were exposed to a parent who had a substance use disorder. Some of us experienced abuse or neglect. All of those things contribute to your adverse childhood experiences. But this is where epigenetics gets really interesting, because even if you're someone who's got the 3-legged stool and you've got this risk of developing something like autoimmune disease or a risk of having chronic cortisol problems because of an experience of trauma, there are ways that you can resolve the trauma in your system. You can turn the volume down. So I used to think that was talk therapy. And when I started talk therapy in my 20s, I wish they did full informed consent. I wish they said to me, "Hey, Sara, you're going to sign up for weekly psychotherapy for decades. You're going to spend a ton of money and a ton of time on it. And the chances that it's going to help you with your A score of 6 is 30%. How does that sound? 70% chance it's not going to work." If someone told me that then, I think I would have been like, I'm not signing up for that. So talk therapy has changed over time. We've got more trauma-informed therapy that's being offered now. But as I wrote the book, and this hasn't changed, I looked at the gold standard of how we treat post-traumatic stress disorder, which is a more extreme form of traumatic experience. Now it lives on in the body, at least mostly mental health effects. But there are other ways that trauma lives on in the body too, that we'll get to. But when it comes to post-traumatic stress disorder, the gold standard is talk therapy with or without selective serotonin reuptake inhibitors. And there's 3 that are FDA approved. Efficacy, once again, 30%. So there's a lot of other ways that we can work with trauma. I prefer somatic approaches. I think those are more effective. I also believe that finding ways to regulate ourselves, finding ways to, um, by whatever means possible, meditation, yoga, Tai Chi, Qigong, all these ways of regulating, especially those of us who got exposed to adverse childhood experiences before the age of 3, we have to learn how to regulate ourselves. It's really critical. So,
Sorry, Sarah, can you just define what you mean by somatic experiences? I don't think everyone understands what is meant by that.
yeah, so the way I think of this is that the part of your brain that understands what happened to you, the part of my brain that understands my parents' divorce, the part of my brain that understands um, some of these ACEs that I have that are elevated, is different than the part of the brain where the trauma is lodged. So when you go to talk therapy, for instance, and you go over and over, here's what my mother did to me, blah, 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 that understanding is a different part of the brain than the place where the trauma is lodged. And so you have to work differently with where that trauma is lodged. The way you work with it differently is through somatic methods. So another way to think of this is instead of top down, which is what most talk therapy is, like, okay, here's what was going on with my mother. She was 21 when she had me. Here's my understanding of what she was going through. Top down does not help resolve the trauma. Bottom up seems to help resolve the trauma. Bottom up is where we are regulating ourselves. We're taking deep abdominal breaths, which you can do with me right now, because I always forget when I'm on a webinar. Bottom up practices are ways of noticing the signals that the body is sending to you. So you mentioned somatic experiencing. Somatic experiencing is one form of somatic therapy. There's things like EMDR. There's things like, I love Hakomi, because Hakomi is a form of assisted self-study that helps you work with the intelligence of the body. So one thing that happens for a lot of us who experience trauma, and I'm going to put you on the spot and see if you have this too. I became hypercognitive. So my way of coping with trauma was that I would go upstairs and I would ignore my body and I would think my way through the problem to solve it. So that neuroplastic effect, that groove got worn and worn and worn and worn. And so I got really good at it. And I would basically functionally dissociate from my body in order to make it through and solve the problem. Now, the problem is when you're in your 40s and 50s, that strategy kind of stops working, especially when you have kids and your kids are like, ah. So it's that's one approach. Some people go down more the PTSD route. They've got more depression or anxiety or flashbacks and other hypervigilance. And then some of us go down more of a hormone route where we chronically make too much cortisol until we don't anymore. And some of us can have this functional dissociation, which, by the way, medical school selects for people who are really good at functional dissociation so that you can be in an emergency room and you can deal with trauma and you can deal with people who come in and they've got, horrible car accidents, and you can still do the work that needs to be done under stress. So what about you? Yeah. What's your experience?
Well, I think we have a great deal in common. And I have lived my entire life. I say two things. One is in my head and the other one is in fight or flight, which is that cortisol driver. And it was only recently that I even realized or was able to acknowledge that I have lived my entire life in my head. And it's a survival technique. It's a very, very effective survival technique for handling trauma and stress and change and children and work and startups. And I never even perceived that there was an alternative for me. But the other thing I realized, which is when you talk about regulation, is I literally was living my entire life in a fight or flight mode. So that just driving my cortisol and all those hormones all the time. And then eventually what happened was, autoimmune, Hashimoto's, exhaustion, bad sleep, and a whole lot of other stuff. And I was like kind of running out of fuel, that I just couldn't do it. And so understanding that there was a way to connect with my body and ground myself and regulate myself was a complete aha for me, a real epiphany, and understand that the way I'm going to thrive in the next 2, 3, 4 decades of my life is by getting out of my head and being able to do the things that you talk about. So I'm a huge fan. I wish I'd known this 20, 30 years ago. I did 30 years of talk therapy, spent thousands of dollars. And, it helped on a day-to-day level of skills, but it certainly didn't resolve anything. And so, yes, I'm a fan. And yes.
Yes. There's also psychedelic assisted therapy, but that's a different webinar.
Yeah, that's a different webinar. We won't. That would be part 2. So, so thank you so much, Sara. And so each of these topics we could spend an hour on. We don't have time, but we have some amazing questions, and I'm going to jump in and try get to the bottom of some of these. So we're gonna shift now before we go down that road. Okay. So I know the one thing that I briefly shot through is let's go back to the hormone questions. There is a question about, but how do I access the kind of doctor who will do hormone tests and give me bioidentical hormones and not synthetic? And I have a little bit of an answer, but I would love to hear your answer.
Well, we have to demand it. So, the old days were that you would go to your doctor and you would talk about your symptoms and they would say, no, I'm not going to do a hormone test. And how about some, an anti-anxiety pill or a sleeping pill or something like that. So we can't tolerate that anymore. We have to change it. It needs to be grassroots because it's not going to come from conventional medicine. So fortunately, there's a lot of telehealth platforms now where you can bypass your conventional doctor if they are an obstacle. But I would say find a different clinician.
Mm-hmm.
I think that overall, physicians tend to be more stuck in the old paradigm. I find that nurse practitioners and often nutritionists and other people trained in functional medicine are more open-minded. So I would say find a collaborative clinician first and foremost. Do you want to add to that?
Yeah, I do. So it's a couple of things, because I've had this experience of going through primary care and being told when I was young, actually, you're going to go on HRT, and there was no testing, no conversation. And, Sara and I are very lucky, we can advocate for ourselves and say, no, that's not good enough. We know there's an alternative, but we realize that that's not the case. So there's a couple of solutions. So one thing I'll ask Candace to post on our chat is we have an amazing practitioner locator of incredible clinicians across. This is only USA based, multidisciplinary, who come from the world of functional, integrative, lifestyle, all those different beautiful worlds that you can go and you can look for a clinician. We know that every clinician there is being vetted by us, and they are the best of the best. So that's one solution. The other thing is looking for a clinician when you do a search that has the word functional or integrative in. And I loved your conversation around, I love nurse practitioners. I really, really do. Physician assistants as well. Sometimes the MDs are the hardest to get past. So it's always better to go through, and not everyone is an MD like Sara. So look for the words functional, integrative, lifestyle medicine, and look for, as I say, those ones under the MD, which is nurse practitioner, some of the best, there's some excellent nutritionists, dietitians, but look for the words integrative and functional. Don't get stuck down the traditional dietetics route. That's not going to help you. But yeah, I think mostly I just wanted to say, don't advocate, never accept until you'll know. Again, connect with your body, what is comfortable for you and what feels right for you. And if you're not happy, change doctors or change practitioners. Do not stay, because that's often where the problems come is you feel like they're the authority, but something's not right. So I would say, jump from that. Okay, thank you. Thank you, Sarah. Some of these questions are very, very deep, kind of biochemical. Sorry about that. I'm going to jump over a few of them. Is there an age where you're too old to start hormones?
I would say you're never too old. When it comes to the Women's Health Initiative, one of the things they found was that if you start hormone therapy too late, if you start it in the conventional paradigm at age 63 or older, we think that that's associated with a greater risk of cardiovascular disease and potentially a greater risk of dementia. But again, that's with synthetic hormones, which I have not prescribed for 30 years. So with bioidentical hormones, we think it's safer. That said, the largest randomized trial that we have is the Women's Health Initiative. So we have to parse the data and see what we can learn from it. What we know is that when it comes to risk, we think that if you're within 10 years of your final menstrual period or menopause, or if you've had a hysterectomy, an FSH that's over 25, if you're within 10 years of that, it's still considered safe, that all the benefits outweigh the risks for you to start hormone therapy within 10 years. Once you're past 10 years from menopause, and my menopause has only recently happened at age 57. So if you're within 10 years, we think you're safe. If you're past 10 years, it becomes more of a quality of life decision where you have to weigh the benefits and the risks. That's where genetic testing, I think, can be very helpful, and have a conversation with your clinician. I have had patients that I've continued on hormone therapy who were more than 10 years from menopause, but it's a case-by-case situation. So the party line is that you need to start it within 10 years of menopause. That's what the North American Menopause Society teaches. And beyond that, it has to be a case-by-case situation.
Thank you. Kim has a good question. I like this one. So if a woman is anxious and can't sleep, I'm going to give my little bit and then I'm going to hand it to you. So if a woman is anxious and can't sleep at any age, how do you know if it's neurotransmitters or hormones? Do you test the hormones first? So we don't know actually, right? Because disrupted sleep can be multifactorial, and it's often not only one thing, it's going to be multiple things. So this is where the genetic test is extremely valuable. Remember, genetics is not an absolute answer. It's not going to give you, I looked at the genetics and this is what's happening. What it does give you is insight. So we talk about genetics as insight. So when you're seeing a patient with this, and I'm going to hand it to the doctor, is you want to know what's going on with them. You want to know where they are and know all the things that you would want to know, but you also want to know their genetics, and you're probably going to do some blood work. But the genetics is going to give you quite a good indication of, is there an issue around hormones? Does this individual have SNPs or gene variants that are disrupting the optimal function? Does this individual have SNPs that might be impacting how they manage neurotransmitters and brain messages? Is it potentially impacting glucose and insulin? Is it potential? So it's all these things. And this is why we always talk about genetics as a screening tool right up front for insight rather than absolute. And then you want to look at all the other things. But I'm going to hand it now to Sarah.
Yeah, well done. So I would say for the patients that I'm taking care of who come in with anxiety and they can't sleep, I want to hear the story. Like, is this something that started in childhood and it's been lifelong? Is this a woman who's postpartum, which is a preview of coming attractions in perimenopause? That's a really common time for the start of sleep disturbances and also anxiety. Is it a woman who's right in perimenopause? And we think that it's a combination of hormones and neurotransmitters. We talk as if they're separate, but the truth is they're so interdependent. And as Yael was describing, genetic testing can be so helpful to figure that out. So, in some ways, we never really know. We just assume that there's a bidirectional relationship between neurotransmitters and hormones, and we can make some good assumptions based on genetic testing. Neurotransmitter testing, in terms of looking at urine and what's happening with neurotransmitters, we used to do that like 15, 20 years ago, and I think it just doesn't work very well. It's not so reliable. But doing hormone testing together with looking at genetics can be really informative. And then the other thing that's really critical is to look at lifestyle medicine. So I can tell you, patients that I have who are anxious and can't sleep, regardless of their age, whether they're in their 20s or their 40s or their 60s, I'm going to get you off of alcohol because it causes anxiety the next day and it disrupts your sleep. And I'm going to get you off caffeine because caffeine tends to jack up your cortisol and make it difficult to sleep. And if you're someone like me who's really sensitive to caffeine, I can't even have it at 6 a.m. It still affects my sleep. I just went off of caffeine for a month, and lo and behold, my deep sleep improved, my total sleep improved, my heart rate variability improved. I'm too sensitive to use caffeine. And then I think a wearable is also really helpful. So I use different watches, things like Garmin and Whoop and Apple Watch. I find that Aura Ring is really accurate. I also am using 8 Sleep right now, and I find that to be really helpful. It uses artificial intelligence to optimize your sleep each night, especially with cooling, which we like for women of a certain age, above 40. So those are some of the things that I think of. I think this idea that we want to know whether it's neurotransmitters or hormones is in some ways kind of a false dichotomy. We want to know, how do we optimize that interface between hormones and neurotransmitters?
Excellent. Thank you. All right. So I think John asked a really good question, and I know we touched on it briefly. And a while back, Sarah, we did a really fun webinar with yourself and Dr. Miles Spa, where we spoke about male hormones and female hormones. One of my favorite webinars, but Miles is not with us today. So John's asking, can you just speak a little bit more to the role of hormones in men, especially things like estrogen, for example, which we never hear about? I think men's hormones, we're actually doing a webinar next month on men's hormones because it is an area that is underserved. So maybe we could just talk about it for a minute.
Oh, for sure. We can invoke Miles because I've learned so much from him about men's health and about hormone balance in men. So the way that I think of it is, know your genetics, because genetics tells you a lot about what's going on with testosterone and how that might convert to estrogen. With men, what we want is a certain level of testosterone and we want a low level of estrogen. You need some estrogen, but you want it to be a relatively low level so that you don't have gynecomastia, you don't have breast stimulation, you don't have um, uh, the inflammation that leads to more production of estrogen. So when I think of men, I think of environmental exposures, things like phthalates and bisphenol A. Those can all affect your testosterone balance and also increase your estrogen production. I think about over aromatizing. So testosterone in the steroid pathway, testosterone converts to estrogen. And if you're someone who over aromatizes, it could be from a number of different reasons. So some of it can be genetic, and maybe you can speak to that. But sometimes it's because of insulin resistance, which was part of my experience when I was younger. But for men who have insulin resistance, where their cells are numb to the insulin signal and their insulin keeps climbing and leads to more fat storage and more estrogen production, that's not a healthy thing. And it can contribute to obesity. It can contribute to having lower testosterone levels so that you don't see a response to, for instance, weightlifting or strength training. So I think those are really important and also relevant for women because this whole pattern in men of low testosterone, maybe with or without elevated estrogen, is something that we also see. Um, it's akin to polycystic ovary syndrome in women with insulin resistance as part of the root cause. So, do you want to say more about the
Well,
genetics
I
of?
would love to, but we've only got a few minutes left. And so I'm watching time. Time has just flown, and you and I can talk for hours. So I just want to make sure everyone. So there are some fantastic questions, and we're not going to be able to get to them. So I just wanted to kind of do a little bit of housekeeping, so we do it before we leave. So the first thing, Sarah, if all your books are available on Amazon, is there anywhere else you'd like to send people to read about the work you're doing and where they can find you?
Well, I would say go to SarahGottfriedMD.com. I'm in the process of a name change. I went through a divorce last year, but SarahGottfriedMD.com is where a lot of these things are topical. You can sign up for my newsletter. You can hear about the next book on regulation. So come join the party.
You're just going to give us a little teaser,
Little
regulation,
teaser.
the next book. Little teaser.
Regulation.
Okay, love that. But I think for most of us, most people here probably haven't read Autoimmune Cure, so we can start with that while we're waiting for the next one. All right. So, and that's SarahGottfriedMD.com. I think they've put that in the thing. Okay. The second thing is, if you buy a 3x4 genetic test from our website, which is www.3x4genetics.com, and there is a link in the chat, you will get this book. It's not a New York Times bestseller. I'm not Sarah, but you will get the Power of Genetics ebook, which will give you a really good insight for those of you who are not familiar with genetics of how it works, why it's important, and all the different things we can learn about that. So you will get a download of that ebook when you purchase a test, and there's lots of links there. But Sarah, there's one question. We got 5 minutes, and I couldn't resist. I had to keep it for the end. It was just perfect. I couldn't have said it better myself. So thank you, Rachel, for this question. Besides testing rigor, what are the reasons that as a practitioner, you prefer 3x4 genetics apart from other nutrigenomic testing companies out there?
There's so many reasons. I would say the number one reason is that it's news you can use. So I've been doing genetic testing for a few decades. A pathway-based approach makes all the difference in terms of being able to help my patients. So the last count that I had with 3x4, there's 157 different gene variants that we're looking at. Maybe the number's changed. I'm not sure. You can tell me, Yael. But 157 of the most proven, clinically substantiated, modifiable gene variants. And I feel like that really sets me apart as a clinician because it lets me look at that edge, that interface between genetics and biomarkers so that I can help my patients optimize their health. So that's why I use 3x4. I think it's the best test that's out there.
Thank you. Thank you, Sarah. So I think that's a beautiful place for us to finish. I know there's a couple more minutes, but I think we've done extremely well. There was an incredible amount of content that we got through. I am sure that everyone is going to have a lot of stuff to think about, go and learn about, and hopefully advocate for themselves as well. So Sarah, thank you so much for your time. It's been wonderful as always, spending time with you and getting to ask you these questions. And thank you to everyone. Thank you to the 3x4 team who made this happen. We have an incredible team behind the scenes. And thank you to everyone who joined us today and is present. Sarah, would you The last comments left for you.
Oh, well, I just want to say so many things that we were taught that we inherited, in terms of risk. So many things like, I started this conversation talking about my fears, like breast cancer and Alzheimer's disease. So much of this, you are in full power to modulate. You can really influence your risk of chronic disease. It starts with your lifestyle, it starts with knowledge. Knowledge is power. And so I would really encourage those of you who listen to us today to understand that you've got more power than you realize. And one of the ways that you can step into it is to really understand your genetic code, know your blueprint. So I would say test yourself, start to look at some of your biomarkers, start to look at the dashboard of what is most important and maybe what your risks are, and then start to do these N of 1 experiments to reduce your risk of chronic disease, to help you feel like you're living your life the fullest. So that's what I would want to leave our listeners with.
Perfect. Perfect note. Thank you, Sarah. Thank you, everyone. Have a great day, everyone.